This presentation will cover adenocarcinoma of the colon, which accounts for more than 95% of all malignant tumors of the colon. The incidence of adenocarcinoma of the colon is estimated to be about 140,250 in 2018, and this represents 8.1% of all cancers, making it the fourth most common type of cancer in the United States. There's a 64.5% 5-year survival based on data from 2008 to 2014, which makes it considerably more survivable compared to lung and brain cancers that we studied in the last case. Most of patients are asymptomatic and tumors are discovered by screening. So part of the better survival is attributable to the discovery of early asymptomatic cancers. Symptoms that are associated with colorectal cancer are typically associated with growth of the tumor into the lumen, causing blood per rectum, or invasion into adjacent structures associated with abdominal pain. I'm going to talk about some of the pathogenesis behind colorectal cancer. The study of familial adenomatous polyposis syndrome provided much insight into the development of sporadic colon cancer and led to an appreciation of the morphologic and molecular changes in the adenoma carcinoma sequence, and this accounts for up to 80% of sporadic colon tumors and typically includes mutation of APC early in the neoplastic process, and that's what's demonstrated by this image to the furthest left. Both copies of the APC gene must be functionally inactivated either by mutation or epigenetic events for adenomas to develop. APC is a key negative regulator of beta-catenin, which is a component of the WNT signaling pathway. The APC protein normally binds to and promotes degradation of beta-catenin, but with loss of APC function, beta-catenin accumulates and translocates to the nucleus where it activates the transcription of genes that promote proliferation. Additional mutations accumulate, including activating mutations in KRAS, which promote growth and prevent apoptosis. And the neoplastic progression is facilitated by mutations in other tumor suppressor genes, such as those including SMAD2 and SMAD4, which are effectors of TGF-beta signaling that in turn promote remodeling of the tumor microenvironment and tumor invasion. Although it appears from this sequence that there's a temporal sequence of changes, it's really the accumulation of mutations rather than their occurrence in any specific order that's most critical in carcinogenesis. The other pathway or major pathway for carcinogenesis has been discovered through appreciation of patients that have hereditary non-polyposis colorectal cancer, or Lynch syndrome. Lynch syndrome is the most common cause of inherited colorectal cancer. It's characterized by a significantly increased risk for colorectal cancer and endometrial cancer, as well as a risk for several other malignancies. Hereditary non-polyposis colorectal cancer, or HNPCC, refers to patients and or families who have a history of young onset of colorectal cancer, in addition to a family history of 3 colorectal cancers involving 2 successive generations. We use the term Lynch syndrome to refer to patients and families with a germline mutation in one of the DNA mismatch repair genes or in the EpCAM gene. And so study of these patients has provided insight into another mechanism. We'll talk a little bit more about Lynch syndrome. Lynch syndrome is an autosomal dominant disorder that's caused by a germline mutation in one of several DNA mismatch repair genes, or loss of expression of MSH2 due to deletion in the EpCAM gene. The mismatch repair genes that are associated with Lynch syndrome include MLH1, MSH2, MSH6, and PMS2. As I mentioned in the talk on polyps, sessile serrated adenomas are frequently associated with this microsatellite instability pathway, and so this is the other major pathway for the development of colon cancer. If you remember, the role of the DNA mismatch repair system is to repair or to maintain genomic integrity by correcting base substitution mismatches as well as small insertion deletion mismatches that are generated by errors in base pairing during DNA replication. Normal MMR requires the coordinated function of several different gene products. The MMR system recognizes base pair mismatches by two heterodimeric protein complexes. Inactivation of both alleles of one of the mismatch repair genes leads to defective mismatch repair. As a general rule, patients with Lynch syndrome have a germline mutation in one allele of the MMR gene, while the second allele is inactivated somatically by mutation, loss of heterozygosity, or epigenetic silencing by promoter hypermethylation, the second step. Biallelic inactivation of MMR genes in a cell then causes an increased mutation rate called genomic instability due to a failure to repair DNA mismatches that occur during normal DNA synthesis. DNA mismatches commonly occur in regions of repetitive nucleotide sequences which are called microsatellites. Thus, a characteristic feature of loss of mismatch repair in tumors is the expansion or contraction of these microsatellite regions in the tumor compared to normal tissue. This leads to microsatellite instability, or the mutator phenotype, and is characteristic of Lynch-associated cancers. Similar to FAP, then there's a progressive accumulation of mutations in cancer-related genes that is thought to drive the process of carcinogenesis, leading to adenocarcinoma in Lynch syndrome. And this same process occurs in a subset of patients that have sporadic cancers, especially those associated with sessile serrated adenoma. So MSI is not specific for Lynch syndrome, and approximately 15% of sporadic colorectal cancers also demonstrate MSI. However, sporadic MSI high colorectal cancers typically develop through a different mechanism. That is through a methylation pathway called CpG island methylator phenotype, or CIMP, which is characterized by aberrant patterns of DNA methylation and frequently by mutations in the BRAF gene. These cancers develop somatic promoter hypermethylation of MLH, which leads to loss of MLH function and the resultant MSI, or microsatellite unstable phenotype. It's very important, high-yield information, to remember the extracolonic manifestations of Lynch syndrome. The most common extracolonic tumor in Lynch syndrome is endometrial cancer. The risk of endometrial cancer, however, varies depending upon the MMR gene that's mutated. Individuals with Lynch syndrome are also at increased risk for cancers of the ovary, stomach, small bowel, hepatobiliary system, renal pelvis and ureter, the brain, and sebaceous skin neoplasms. Okay, with pathogenesis aside, let's talk about some of the morphologic features of adenocarcinoma of the colon. Grossly, colon cancers may be polypoid, exophytic, or fungating, ulcerative, diffusely infiltrating, or obstructing. in which tumors produce circumferential narrowing of the bowel lumen, sometimes called a napkin ring carcinoma. Polypoid cancers, such as that depicted in panel A, are papillary, lobular type masses that protrude into the lumen, and are more common in the cecum and right colon. In contrast, ulcerative carcinomas deeply invade the colon wall with an edge that's barely discernible from the adjacent mucosa, which as you see in panel C. Ulcerative carcinomas are more common in the left colon or rectum. Fungating tumors, which you see in the middle panel, are a mixture of these two patterns, characteristically seen with a central cratered middle and a raised rolled edge around the periphery. Adenocarcinomas of the colon are graded or appreciated according to their degree of glandular differentiation, and this is a general rule of grading for adenocarcinomas. Well-differentiated adenocarcinoma, like that seen in panel A, are predominantly composed of uniform elongated tubules, and the nuclei retain some of their polarity. That is, they're mostly located along the abluminal portion of the gland and show nuclear pseudostratification, and they show obvious cytologic atypia. Moderately differentiated adenocarcinomas still make tubules, but architecturally are more complex and frequently contain these large cribiform type glands. Poorly differentiated carcinomas, like on the right, are mostly solid with minimal gland formation and are often seen as sheets of cytologically malignant cells with complete loss of nuclear polarity. A key high-yield histologic hallmark of colon or colorectal adenocarcinoma is this presence of dirty necrosis. Now, what this describes is the accumulation of necrotic debris and degenerated neutrophils in the center of malignant glands, and it's this eosinophilic granular material. Again, if you see the term dirty necrosis, think colorectal adenocarcinoma. There's an important high-yield histologic variant that you need to know about in colon adenocarcinoma called mucinous, or sometimes colloid adenocarcinoma. These account for 10% of all colon cancers and about 30% of rectal cancers. This variant is more commonly associated with HNPCC, as well as sporadic carcinomas that arise with sessile serrated adenomas. They have a characteristic histologic appearance in that they're cytologically malignant glands that are disrupted by the accumulation of abundant extruded intraluminal mucin. And so this creates mucin pools in which you have free-floating malignant cells. This additional type of signet ring adenocarcinomas describes these cells that have very prominent intracytoplasmic vacuoles of mucin. So the mucin is intracellular, producing this signet ring type of appearance, and these clusters of cells again float in this in these pools of abundant mucin. By definition, we call mucinous adenocarcinomas when there's at least 50% of the lesion shows these mucinous features. A variety of serum markers have been associated with colorectal cancer, particularly carcinoembryonic antigen, or CEA. CEA is a type of glycoprotein produced by cells of the gastrointestinal tract during embryonic development, but it's produced in very small amounts after birth. Unfortunately, CEA has a low diagnostic ability to detect primary colorectal cancer due to significant overlap with benign diseases, including gastritis, peptic ulcer disease, diverticulitis, liver disease, COPD, diabetes, basically any acute or chronic inflammatory state. In addition, CEA levels are also significantly higher in cigarette smokers than non-smokers. CEA also has a low sensitivity for early stage disease, so it's not useful in a screening setting. However, CEA levels do have value in the follow-up of patients with diagnosed colorectal cancer. Serum levels of CEA have prognostic utility in patients with newly diagnosed colorectal cancer. Patients with preoperative serum CEA greater than 5 nanograms per ml have worse prognosis stage for stage than those with lower levels. Also, elevated preoperative CEA levels that do not normalize after surgical resection imply the presence of persistent disease and the need for further evaluation. The most common sites of metastasis for colorectal cancer are the mesenteric or perirectal lymph nodes, the lung, as demonstrated in this image, and the liver, which is demonstrated in this image. In metastases of colorectal cancer, there's a recapitulation of the same histologic features that we see in the primary tumor, including the presence of dirty necrosis, which we see here. Dirty necrosis, which we see here. Staging of colorectal adenocarcinoma, in contrast to lung, for example, in which, at least with the lower tumor stages are associated with tumor size, the staging in colorectal adenocarcinoma is based on the depth of invasion into the wall. So tumors that are limited to the mucosa, invading the submucosa, invading into the muscle, or invading through the muscle, constitute tumor stages TIS through TI3. And then finally, the invasion of tumor into the visceral peritoneum or adjacent organs constitutes T4. The nodal staging is based upon the number of nodes that are involved, and the M part of the criteria, just like other tumors, is based upon metastasis to distant sites. Finally, there are additional prognostic or predictive factors that are frequently assessed in patients with colorectal adenocarcinoma. These are considered important in making decisions about treatment, but are not yet incorporated into formal staging criteria. As we talked about, the preoperative CEA levels provide prognostic information. The tumor regression score, which reflects pathologic response to preoperative radiotherapy, chemoradiotherapy, or just chemotherapy, and the status of circumferential resection margins are important for rectal cancers. Lymphovascular and perineural invasion in the absence of detectable lymph node metastases also provide prognostic information. Evaluation of microsatellite instability, which reflects deficiency of mismatch repair proteins, is both a prognostic factor as well as a predictive factor of lack of response to fluoropyrimidine therapy. Finally, mutation status of KRAS, NRAS, and BRAF provide predictive information because mutations in these genes are associated with a lack of response to epidermal growth factor receptor, or EGFR, targeted agents. All right, that's it for colorectal adenocarcinoma. Thank you.